All right. Good morning, everyone. I think it's 7:32. So thank you all for joining this morning for this most prestigious lecture of the Heart Institute, the Dr. Kian Endo Lectureship. I don't need to remind anyone who was Dr. Kian, the founder of the Heart Institute and one of the greatest heart surgeons in Canada, in Canadian medical history. So we are very, very pleased to have today Dr. Niv Ad, who is a cardiac surgeon from the United States. So I know Niv for a long time. Niv has been a friend. He's currently a professor at Hopkins. He has led many cardiac surgical groups, has been a pioneer in valve surgery, arrhythmia surgery in particular. And he was trained initially in Israel, and then he moved to United States and got his fellowship with Jimmy Cox, and he's past president. As you know, Jimmy Cox is probably one of the most iconic heart surgeon for arrhythmia surgery, and so Niv is as president of the International Society for Minimally Invasive Cardiac Surgery. And of course, it's a great pleasure to have him here. So as I said, I know Niv for a long time. What always amazed me with Dr. Ad is his intelligence and his ability to innovate. And so to me, he's the example for young heart surgeons of what a cardiac surgeon must be, which is really be not only good with his hands, but very good with his head or her head. This is really very characteristic of Dr. Ad. I think putting in things in his new mind to be able to procure and to deliver the best technique and the best care to the patient. So without any further ado, please, Niv, I'm very excited to hear from you with this talk on minimally invasive cardiac surgery, a gimmick or a necessity. So Dr. Ad, your turn.
Good morning, everyone. Thank you, Terry, for this kind introduction. I'm very excited to be here by myself, sitting, talking to you, but obviously these are different times. I find this invitation a great privilege and honor, and I hope that you will find some of my thoughts at least interesting, so we can have a good discussion. I have a lot of slides, so I'll try to start. These are my disclosures, and I'll share with you one more disclosure that's not commercial later on. So the title is pretty provocative, and it means just to make us all think, especially myself. You know, after preparing this talk, I actually solidified a few points that I wasn't clear about, and I wasn't really aware of it. So what's a gimmick? It's a trick or device intended to attract attention, publicity, or business. So if we agree that minimally invasive procedures are a gimmick, then we only do them in order to increase our referrals. And that's I think, a valid point, and we need to actually dive into it. If it's a necessity, it is indispensable, and minimal invasive cardiology then will be necessary to improve patient care. So let's see what we feel about it. What is the data, if there are data, and so on and so forth. So the short answer to the question is obviously it is not a gimmick, and it's all about patient care. I know that some of you already say, well, let's see, you know, it's not better in X, it's not better in Y, it's inferior in Z, and so on and so forth. So yeah, it's a very complex challenge and problem. So why do we debate? the everyday practice is surgeons dependent. At the end of the day, when I'm getting a referral, I'm sitting with the patient in the room, and based on my, experience, eye test, and you name it, I make a decision. What is the approach I want to choose for this particular patient. I feel lucky because in my armamentarium I have a few options. It's not just a mid-sternotomy, and I hope that my patients feel the same. The decision, minimally invasive or not, is hard, and it's impossible to standardize. There are perceptions, the reality, and definitely it's hard to generate data through RCTs. I would say it's impossible to generate RCTs, and I'm not a big fan of multi-center RCTs, for cardiac surgeries especially. And let me share with you one data point. Why is it so difficult to generate RCTs in cardiac surgery? I think in surgery in general, but in cardiac surgery. Let's look at something that looks completely irrelevant to the point of minimally invasive yes or no and RCTs, but I think it's very relevant. And this is the state of Maryland, and we just published this paper. Number and type of blood products are negatively associated with outcomes following cardiac surgery. These are the blood transfusion rates, the total blood transfusion rate and intraoperative blood transfusion rate by RBC, non-RBC here intraoperatively by centers throughout the state of Maryland. There are 10 centers, now we have a new one, so there are 11 centers in the states of Maryland. And you can see center number 1, 2, 3, 4, 5, and so on and so forth. And you can see that for the same procedure, the transfusion rate is different. And why it matters? Because if you look here at the spline, there is the red line for RBC and the blue line for non-RBC. The more you transfuse, the higher the mortality at 30 days. So we all look around. We have a group of surgeons, even in the same hospital. Some are considered more sloppy than others, and they have higher bleeding rates. Or some would simply like to transfuse any patients with hemoglobin less than 9 and so on and so forth. That's not criticism. That's a different debate whether you should or shouldn't. But we know that blood transfusion is basically associated. The more you transfuse, the more complications you have. Now it may be just a marker, but it probably has some physiological aspects to it that I don't have time to dive into. So what's the point? If I do mitral valve repair in center number 4 in Maryland, the chances to be transfused are very high. If I do it in center number 3 or 2, the chances are a little bit lower. So how is it going to impact the outcome? So if I randomize patients for mitral valve repair, minimally invasive versus not, and we have a confounding variable that is completely not within the scheme of the trial, it's going to be very hard to reduce noise and bias and get valid results. So I'm a proponent of RCTs where everything is the same, management of the patient pre-op, intra-op, and post-op. So the single center RCTs are actually in cardiac surgery maybe the way to go. A couple of other centers, together that have the same protocol, strict, and so on and so forth. So very hard to put those together. Now, that being said, we should, to some extent, use reliable observational data from experts and big centers to complement our decision making if we want to practice evidence-based medicine. This is an opinion. It's not based on any hard data beyond what I just told you. So the debate. The surgical approach per se is not associated with improved results of the index procedure. We know that open cholecystectomy was a very successful, before the scope and scope or endoscopic, laparoscopic cholecystectomy. That's what we are doing today, but we didn't 20 years ago as across the board. we know it's the same efficacy for the actual cholecystitis or whatever the indication was. Successful mitral valve repair in experienced hand is not dependent on the surgical approach. I can do mitral valve repair as well with a cross clamp, arrested heart, mid sternotomy, as with fibrillating heart through a minimally invasive approach, depending on obviously my experience and patient selection and so on and so forth. So we do debate something that I want to actually sway your attention to, which is probably beyond the actual results of the procedure. So we have the patient, he or she or he, they're coming to us, they have a problem, a cardiovascular problem, and they have either medical therapy, catheter-based procedure, or surgical intervention for, most of the problems we're dealing with today. But let's focus on the surgical intervention right now. So there is a patient choice, and the patient choice is dependent on basically what we tell them. What we tell them mainly about recovery and somewhat about outcome, and I'll get back to it in a second. But they also read the internet, and they come with all sorts of things, especially the folks that are having valve surgery, mitral more so than aortic, but it is out there. I read about so-and-so doing it, through, the inner ear or something like that. What do you think about it? And then you have to go through this in a very serious manner and explain, one thing to the other. But the patient choice is based on that discussion. The surgeon's choice is based on his or her or his experience, outcome, and obviously referring entity expectation. I often get a call, I have a perfect patient for you for mitral valve repair for a minimally invasive. And then, in the office, there is a bariatric patient, 400 pounds, coming in, and that the referring cardiologist really didn't pay attention to what are the basic rules of minimally invasive procedure for safety and efficacy. So we have this dynamic between the patient and the surgeon, and we know that this dynamic is well established with evidence. The connection with the patient, the institution, and the reputation and the trust are all developed mainly around that simple meeting in the office or bedside, and somewhat now with what's on the internet about you and what other patients are telling about you, and so on and so forth. So less invasive mitral valve surgery versus conventional sternotomy, stratified mitral pathology. That's a paper that was led by Tom Wynn, my good friend from UCSF, and was published a year ago or so. So as you can see here, in the bottom, you have in blue the rate of mitral valve repair done minimally invasively in the US versus conventional sternotomy. So only 1/4 of the patients in the US for mitral valve repair are being done minimally invasively. Some of the authors here of this paper are not doing minimally invasive procedure, and some of them are well-known mitral valve repair surgeons. Now, this is not a criticism, but I want to show you that this is probably cultural also, because in Germany, over 60% of the mitral valve repairs are being done minimally invasively. So when we say, oh, and what about training, and what about this, that, and the other, well, it is possible. It's a matter of focus, it's a matter of necessity, but more importantly, a matter of expertise and experience. But the notion is that this is how I do it for many, many years, and it works well for me. It's not necessarily what's going to work very well for the patient, especially when it comes to recovery. So where is the evidence? It's hard to find the evidence that's going to guide you and say, oh, these are the guidelines, and I'll choose X, Y, or Z for my patient. It is more of the gray areas of how you decide about what to do to the patient. And I always say, if you want, I'll go back to mitral valve. I'll finish with atrial fibrillation. I want to say that when I tell a patient, you are not good for minimal invasive procedure, I think it means a little bit more if someone who never did a minimal invasive procedure say to the patient, oh, you're only good for mid-sternotomy because minimal invasive procedure is going to be a disaster. I want to think this way. I'm not necessarily can back it up with our data, but the evidence is hard to find. So let's look at the principles of successful surgical procedure and try to better understand what the patient is seeing and what we see based on our experience. So what are the principles of successful surgical procedure? The medical aspect is excellent early results, safety, high safety, quick recovery, and long-term results. Sounds like TAVR, but we are talking about surgery now, which is actual surgery. The patient aspect, and I find it stunning. I talk about safety, but most patients, they listen, but I'm not so sure how much they dive into the real risks, the real benefits, and so on and so forth. But they are very, very focused on, doctor, how long am I going to stay in the hospital? How soon am I going to go back to work, driving, and the race of life. So we have to remember that. We see the mitral valve repair. They often see the recovery as the most important aspect. And this is really an interesting point, and I find it crucial because we all have to take a note to that. And I know in your institution, minimal invasive surgery is not just a poster on the wall. You have some very active, including my good friend Mark Worrell, that is leading, the field when it comes to revascularization. No offense to anybody else. This is the name that came up to me right now. So let's go one by one and try to better understand quickly what's going on. Early results. Okay, well, I'm a great mitral valve repair surgeon. Really? What is the definition of successful mitral valve repair? There is no universal definition of successful mitral valve repair. Astonishing, also not for percutaneous mitral valve repair like with MitraClip. It's all about the interprocedural dynamic, I would say. So MR less than +1, I think most people will agree that you shouldn't leave the operating room after open procedure, minimally invasive or not, with more than +1 MR. But is it enough intraop? What about pre-discharge? Mitral valve gradient. Dr. Messana was very, very instrumental in educating all of us about exercise-induced mitral valve stenosis in patients by the kind of the mismatch by too small of a ring and a complete ring, and so on and so forth. But intraoperatively, what should be the cutoff? Is it 2? Is it 3? Is it 4 millimeter of mercury? Is it LA strain? We don't have those definitions. Coaptation surface, is 1 millimeter enough? Probably not. Is 7 enough? Maybe. All of the above, other variables, and so on and so forth. The point I'm trying to convey to you is that even in the big trial, primary and repair that are coming out now to compare mitral valve repair surgically with a clip, there is no definition what constitutes a successful mitral valve repair. You assume that if the mitral valve repair intraoperatively wasn't good, in 1 year they are going to fail. But maybe not. Maybe it's not important. It's very, very important for us to define those things, and we need to work through those hurdles in order to make a better definition of what constitutes successful mitral valve repair. So when I'm talking about early results, I'm not really talking about all that. Most studies report on repair rates. Oh, I repair 99% of my degenerative mitral valves. Oh, and my intraoperative MR is really good as a marker of success. But as we all know, it's not enough. So going back to that other paper that I showed you from the SCS database, so mitral valve repair rate in general for different pathologies, except for rheumatic disease, which statistically it's significant, it's right here. The repair rate, but clinically, I don't think it's significant. The repair rate, of overall repair rate is higher for minimal invasive procedure, degenerative, non-degenerative, ischemic, and so on and so forth. It's not surprising because I think that the 24% repairs minimally invasively done by, generally speaking, very experienced surgeons, and they know they do more mitral valve repairs, so their repair rate is higher. Although one may argue that 80-some% of mitral valve repair for degenerative disease is not high at all, definitely not 64. Let's go to safety. Safety is important. You talk about it with the patient. They don't always pay attention to the details. We are a very optimistic animal when it comes to taking decision about risky procedures. So this is a study from Cleveland Clinic and our good friend Mark Gillinov, 1,000 cases robotically assisted mitral valve surgery. Superb results. They report death, stroke, surgical site infection, atrial fibrillation, reoperation for bleeding, etc., etc. And you can see that the results are actually superb. 1,000 patients, minimally invasive procedure. We have the answer, don't we? Well, look at the patients. Age 56, 80% or so male, and BMI is reasonable, 26. Half of my patients are not these patients. So when you sit with the patient in the office, the patient is 70-year-old, and ask you about safety, you cannot rely on this data because this is really a careful patient selection, very careful patient selection. Those are, relatively speaking, healthy individuals that are having severe mitral insufficiency. I'm not taking anything away from the superb results, don't misunderstand me. But the same we can say about the low-risk trial, SAVR versus TAVR. Average age is not, the average age of most low-risk patients that we see today. They didn't include a lot of things like, bicuspid young patient and so on and so forth. So the relevancy of the data to our patient is really, really important. Quick recovery, very important. And I think this is the focus of what we have to think about when we offer minimal invasive surgery. If we do it well, it's not going to be a better operation on the heart, but it's going to be a better operation on the patient because the patient is going to recover faster. And very importantly, minimal invasive procedures, unlike mid-sternotomy, working very well for frail patients, very well. They actually accumulate quality of life points as good as the other patients that are non-frail. And this is something to consider. Women in general do suffer more from sternotomy. This is a famous Canadian trial, actually, the REST trial that you are all familiar. So many of you, I'm sure, familiar with, showing that sternotomy is not a great deal for many female patients, and unfortunately, there is not enough patients that are being selected for minimal invasive procedure that are female patients because of perception that it's more difficult, but not quite so. And I think they actually, as a group, enjoy a much better and faster recovery compared to their sternotomy partner in the same group. But that's not surprising that minimally invasive is very good early on, and later on, quality of life is actually good. I mean, all of us have many patients that we operated through mid-sternotomy, and a year, 2, 3, 10 years out, 15 years out, they're doing extremely well and they are very happy. Look at the partner trial, the low-risk trial, okay? Look, quality of life at 30 days is abysmal for the 6 week, the 6 minute walk. I mean, is abysmal for the surgical SAVR, and the quality of life at 1 year as you can see, is basically the same as opposed to 30 days after surgery. So we see it in different aspects. When we do a minimally invasive approach, and TAVR is obviously less invasive than any minimally invasive procedure we are talking about it with which consider open surgery, then we see how well patient recover. By the way, the GARI registry, the German registry, is showing the same thing. In 1 year, quality of life is no different between surgery and TAVR. So minimally invasive procedures, when it comes to recovery, I think offer a significant advantage over more invasive procedures. And this is how we do mitral valve repair. This is a P2 prolapse. I do minimally invasive in most of these patients, and we don't cross-clamp, we do a fibrillating heart. And for you that are doing it all the time can appreciate how the tone of the annulus is important. The valve is not collapsed, so I think it's more realistic in terms of sizing and so on and so forth. This is my old technique with so this is an older video with the loop. I completely abandoned it now. I'm doing so-called freestyle, multiple loops that are being adjusted after the ring is sewn in. But this works well for patients. As you can see here, 4 loops are into this large P2, creating a new coaptation surface. And after landing the ring, flexible ring with core knot, you can see that you don't have to do a water test because the valve is competent. And as you can see, a good coaptation surface, very low gradient, and no MR. That's our technique done in a few, well over 1,000 patients, and we published quite a bit about it. So this is interesting because we were asked multiple times what our results. So with a few hundreds patients initially, this is an older paper from 2015, presented I think 2014 in EX. You can see that mid-sternotomy versus minimally invasive in our hand and after propensity match. Obviously, we couldn't match so many. We started with over 100, so it's kosher. But as you know, the selection for mid-sternotomy was a different kind of patient. But overall, look, the TIA stroke extremely low. After the matching, nothing. Major morbidities extremely low. And operative mortality, obviously in the mid-sternotomy there were 4 patients, but in the minimally invasive there were no patients that died. So there is some selection here for the minimally invasive, and I can talk to it later on. Thierry and Mark asked me to talk a little bit about atrial fibrillation in the context of this minimally invasive, although atrial fibrillation is a different problem. But I think it's important. So how do we do in minimally invasive procedure with atrial fibrillation when it comes to surgical procedure? This is again an STS database generated data. As you can see in the red, this is between 2012 to 2016. But I can tell you, we looked at the data in the past 5 years. It's kind of the same. We are up to about 1,500 isolated procedures a year. What's striking, though, is that there is the gold standard, the on-pump MACE procedure is almost not done. I think I have most of these patients here because that's how I do it still, mostly. 80% and more are being done off-pump. The Wolf procedure, or what have you, TT MACE, or now the Converge. And that's a big point of concerns and actually decision making that I hope we can discuss, if not now, in the next session. Here's the point, though. When we look at those minimally invasive off-pump versus on-pump, the conversion rate for the off pump is anywhere between 4 to 6% and is not changing over the years, meaning that they had a major bleeding and they had to convert. If you converted the patient, mortality is very high. So can you imagine in 2014, among those patients that were converted, 4%, mortality was over 10%. We don't have mortality over 10% in the most difficult procedures today, except for the extreme disasters. I'm talking about, triple valves, that mortality is much lower. Type A dissection mortality is much lower if the patient is not with any, malperfusion or stuff like that at arrival and so on and so forth. And even in 2017, and the reason we have 2014, 2015 is the quality of the data at the SCS database is 5%. And the conversion rate is not changing, which tells you that there are a lot of centers that probably started and stopped this procedure because there is no a normal learning curve which you expect this to be down here right now. So when you convert those patients, you have very high rate of mortality, and this is the Achilles heel of all those off-pump procedures, together with the fact that they are not as effective as the MACE procedure. This is another paper that was published in the European Journal that compared the minimal invasive MACE procedure on and off medication at 1 year to hybrid procedures to standalone off-pump procedures. So on one hand, we have a very high penetration of minimal invasive approaches. Off-pump, I think we will go through the same process as we went with off-pump CABG, especially in lieu of what happened with the Ruby trial and the late results that were published just these past days, showing that long-term effect of off-pump is not beneficial to patients over on-pump procedure. We are now running a huge analysis on the myth of cognitive dysfunction with on-pump procedures that is going to be published very soon. It's a very thorough analysis of the literature published in the past 40 years. So I think all in all, I'm satisfied with the minimal invasive approaches for atrial fibrillation. I'm dissatisfied with the unidimensional decision-making of us as a group pushing into this off-pump procedure without having the appropriate devices to ablate transmurality and to some extent pushing the safety boundaries. So this is, I think, the most important slide in surgical ablation for atrial fibrillation. I purposely didn't put any title here, but I can tell you this is a reflection of a study that failed called the CURE-AF trial. That was an FDA IDE trial about 10 years ago, maybe a little more, that was designed to approve the Medtronic RF platform. Why is it the most important slide? Because it shows you something that is astonishing to me. Keep in mind, same trial, same protocol, same devices, same lesion set. And yet, some centers, 100% success rate, and some center 33% success rate. I know that the ends are not, big, but it is astonishing to me to have such a variability, even in a relatively smaller number of patients. And when we dove into the data, we found some astonishing aspect of the practice of ablation, the lack of understanding of how ablation works among surgeons, and the lack of understanding of how the lesion set is working. So I think it's really, really important to know that the field as itself is, if we were talking about the lack of definition of success for mitral valve, here we are having a huge problem in different aspects of understanding the pathophysiology as a group, applying the right lesion set, but applying it appropriately, using the appropriate technology, understanding the limitation of the technology, and the role of the up-and-coming hybrid procedure. Why is it so complex? And I know if there are EPs on the talk, some of them are not going to really agree with what I say. But this is one of the papers we published on mitochondrial dysfunction and atrial fibrillation. And we biopsied different aspects of this is the left atrium, but also the right atrium. And as you can see with this heat map, and I don't have time to dive into it, on the mitochondrial side and signaling pathways, the left atrium is completely different of patients with atrial fibrillation, completely different than the left atrium of patients with no atrial fibrillation, signaling pathways and so on. So this is the mitochondria itself. Also, we are mapping now a lot of patients using this surface mapping that I think it's a good tool for surgeons because most of our patients are not being mapped. And this is a collaboration I have with University of Vienna and Dr. Ehrlich over there. And we mapped many, many tens of patients. We published a few papers already. And yet, we are yet to find patients that wouldn't have biatrial abnormality when it comes to the electricity of the heart in patients with persistent, long-standing persistent atrial fibrillation. This is all a setup of patients that are coming to surgery for concomitant procedure and are being mapped before, and we are yet to find left atrial only mechanism. So it gets to the point of what is my view about the appropriate ablation. And I am a big proponent of the anatomical approach. I think that we are maybe wasting our time, running after every foci and so on and so forth within the heart when it comes to atrial fibrillation. And we actually have a work that's right now is under review that we sequentially mapped patients 2 times, allowing at least 10 days between the mapping, same patient, no interventions before any surgical intervention. And we look at the pattern of what we see in atrial fibrillation of those patients. And to summarize that study, we found that there are some hotspots, but a lot of differences in the same patients. Atrial fibrillation look different with 2 sequential mapping. Now, this is an oversimplification of the problem, but the way I approach it, and I think this is actually a story that resonated and people really get what I mean about the anatomical approach. This is this bridge in Honduras that was built by a Japanese company to defeat the repeated hurricanes that decimated that area. And they built this bridge that can sustain the highest grade of hurricane. And then Hurricane Mitch came and set over Honduras for quite a few days, a lot of rain, a lot of, demolished a lot of in the area. And that's what we saw after the hurricane passed the area. The bridge sustained the hurricane, but the river moved. And that's, I think, the best analogy to reflect what I think about atrial fibrillation, especially in the persistent, long-standing persistent patient. What we see today is not what we are going to see tomorrow. So we apply a good lesion, which is the bridge, but the problem moved. Therefore, the MACE procedure has this success because it's an anatomical approach, trying to take into account all aspects of atrial fibrillation. And I hope we can talk about it. Let me give you one example of that QRAF slide and why it is not as good in all surgical procedure. I proctored or did surgery in 73 different operating rooms in the US and in the world, helping surgeons to do MACE procedure. And I have a notebook where I collect my conclusions. And except for 2 surgeons, both in Europe, none of the surgeons that I proctored or helped doing the procedure actually performed the procedure as Dr. Cox envisioned it. Now, is it important? I think it is, but it tells you just that there's like this artistic freedom of surgeons to perform procedures somewhat away from how the original procedure was done. And this is why I wrote actually 2 different editorials responding to 2 different papers in Journal of Thoracic Cardiovascular that I gave the title, How Do We Spell Maze? A Dialogue Concerning Definitions and Goals. And the mitral valve isthmus is the most common misconception how to ablate it. So here is the mitral valve isthmus. From the outside, you see the coronary sinus. And we know that we can have what we call the perimitral macrorenal circuit going either within the coronary sinus or that isthmus tissue that's beyond the coronary sinus. So if we perform the MACE procedure, as you can see, or part of it, and we isolate just the pulmonary vein, box or not, we allow that perimitral isthmus to actually exist. And some would say that by actually applying those lesion sets, we create an iatrogenic left atrial flutter, which I tend to agree with it because you almost never see a spontaneous left atrial flutter. So if you ablate it to the coronary sinus from the inside all the way to the mitral valve isthmus, from mitral valve annulus from the inside, you basically block part of the problem because the coronary sinus itself can conduct. Therefore, you have to ablate also the coronary sinus itself from the epicardium. So the lesion going to the mitral valve isthmus composed of lesion inside and outside the heart epicardially, and they have to overlap. Otherwise, it's going to create a situation where if they are not overlapped, we can have some conduction remaining, and we've seen it. This lesion is so important that in the beginning, Dr. Cox used to leave metal clips where we perform this lesion. So if there is a left atrial flutter or atypical flutter or isthmus-dependent flutter in postoperative period, EPs will know exactly where this was ablated so they can go and complete. And here is how I do the MACE procedure. I wouldn't go through all of it because I want to leave some time for talk, but it's a minimal invasive procedure. We do the other procedure. We put a bipolar pacemaker on the RV, and we fibrillate the hearts like we do with mitral, so we don't cross-clamp the aorta at all. Even if we have mild AI, we learn how to deal with it. And we developed this special retractor. You can see very good with the scope. The scope is you can do it direct. Sometimes you can do it with the scope. As you can see, the anatomy is good. There's not too much blood. Appendage here, left upper pulmonary vein, left lower pulmonary vein. The mitral valve is somewhere over there. And I want to show you a couple of, so this is patient with some ablations before, but you can easily perform these lesions without compromising any of the ablations. So we use, in this case, an argon-based device, but we can use also the nitric oxide one, and they're as good. And you go by the ablation scheme. I want to try to advance it a little bit. That's how you see here, appendage is above here. These are the 2 pulmonary veins, and it goes all the way back. But you can tell how well there is the tissue is being ablated. This is interesting. So we go to the coronary sinus. That's the left atrial isthmus, and I think this is a really good demonstration of why it's so important. You see, it's a very potent ablation here, going from the incision to the mitral valve to the P2, P3 area. But now, looking through the oblique sinus, you can tell that it's so thick that the coronary sinus is actually epicardially is intact. And if you remember the diagram I showed you, this will still conduct in many cases, so you defeat the purpose. You see, everything is frozen to it, and sometimes you see beyond it a little bit, but the coronary sinus often is not frozen. Every now and then you'll see it frozen, but you see this is another case, it's a different case. It's not frozen. So the only solution to complete this lesion is to have an epicardial lesion, as you can see here. Again, oblique sinus, the retractor is in the oblique sinus. You see the coronary sinus here, and it's overlapping the inside lesion, so you can see here how it goes. So here it is on the surface of the heart. Very careful not to freeze coronaries and so on and so forth. The last thing I want to show you is something we started in 2013. We are retracting the aorta and basically introducing an atria clip through the transverse sinus, so we don't have to have another incision, and we obliterate the appendage. We've done it now with hundreds of patients, and it works very well. And to our satisfaction, it's now becoming a standard for many performing the MACE procedure, minimally invasively. These are our results for 5 years for non-paroxysmals. I'll go quickly here. I think what's stunning is that if you keep them on medication, some of them do need it. We maintain very high level of success. We do extreme monitoring is extremely diligent. The last 41 patients all have link with a very low burden, close to 90% with zero burden actually, and about 7-8% with a burden of 0 to 0.4%. Be that as it may, off medication, 79% in sinus rhythm, and no arrhythmia over 30 seconds. You have to remember, it's not in atrial fibrillation all the time. I'll show you in a second. It's basically no event longer than 30 seconds. That's a very low bar that nobody understands why. And 73% of the patient never even had a cardioversion in 5 years with a single procedure. And so 50% of the atrial arrhythmias that we had here were 30 seconds to 5 minutes event, very low burden, mostly asymptomatic. But now I'm pushing into a check to take the patient back to 3 to 6 months after surgery in order to check the lines and complete whatever is required to increase the success rate. Stroke rate is extremely low. As you can see, freedom from stroke rate at 120 months, not so many patients, but still a significant 98.3%. with 84% of the patient off anticoagulation at 5 years. 0.1 strokes per 100 patients here. To summarize this talk and allow some time for discussion, minimally invasive procedures, valves, coronary artery disease, congenital anomalies, and atrial fibrillations are offering faster recovery physically and mentally, and short and long-term results should be similar, or as we saw for the mitral, maybe even superior to mid-sternotomy because of the level of the experience. The perception on minimally invasive surgery should be changed in our community through education and training, because it's better for our patients, especially when we look at this faster recovery physically and mentally. And it's unfair not to offer it to patients that can have a successful minimally invasive procedure, because this will be a life-changing in their ability to sustain this trauma, so to speak, of surgery. In conclusion, minimally invasive cardiac surgery is not a gimmick, but a necessity for the reason I shared with you, to improve patients' recovery and satisfaction without compromising outcome. I think we are doing okay for CABG. I would say that the future of CABG is small incision and beating, non-beating heart off pump procedures, but maybe utilizing the pump to allow more accurate anastomosis and faster procedures. Mitral and aortic, I think we are over there. We are all doing well, but still we have to improve the videoscopic approach and some of the tools we have. And in surgical ablation, I think it's a work in progress. The penetration of minimally invasive is excellent compared to non-minimally invasive procedure for standalone. However, the concept of ablation and pathophysiology of atrial fibrillation sometimes are detached. That's all I had to say this morning on the talk, and thank you. I hope we have enough time for discussion.
Thank you. Thank you very much, Niv. Very inspirational talk, and I think I like the way you approached the aspect from the patient side as well. What are the expectations of the surgeons? What are the expectations of the patient? So we have some comments and questions. So I'm going to have a look first. So I think Mark, Dr. Ruel, thanks, Mark, for joining. I know you are supposedly in vacation, but I will go right to his question. So I think he makes some comment that everybody can see. But the question, Niv, is he says basically, how do you see incorporating a safe uptake of minimally invasive cardiac surgery in the career of a young but not quite experienced cardiac surgeon? How do you see this happening? What's your approach? I know you have trained so many young surgeons, so how do you see this integrating the skills of a young surgeon?
Well, first, I think this is an excellent point. You know, maybe we don't have to answer. We just have to go to Germany and see how it goes there, because 60% of mitral valves are being done minimally invasively there. So they found some type of a solution. I think it's an attitude first and foremost. I think the recognition of the importance of the patient recovery is important. Now, be that as it may, it's a challenging training. My story is that the first mitral valve, you know it, the first mitral valve I've ever seen in my life repair was minimally invasive, because I didn't see it before I came to Jim Cox. So for me as a surgeon, you know, and imagine the young surgeons coming today to general surgery, they don't even know what open cholecystectomy look like. So I think this is a transition we have to make. Obviously, cardiac surgery is a little different than general surgery, with the aspects of risk and benefit and so on and so forth. So the one thing I think it's the attitude and the understanding. The second thing is that we should work on training program, and I know many work, especially in Europe now, on simulators and visualization. The robot offers a unique aspect because you have the double console. So you can actually, like you learn how to drive, you have, you know, the teacher and the trainee, you know, looking at the same picture, and they both can drive the machine. So it's an excellent question, but I think it's a psychological aspect and an infrastructure, but it's very doable. You can teach how to do minimally invasive procedure, as well as you can teach how to do an open procedure. It's just a matter of, you know, system.
Don't you think that in Germany, the reason why they have such a high rate of minimally invasive surgery is because they have these huge centers where actually they have 2,000 or 3,000, like Cleveland Clinic, they have thousands of cases, and they, even if they would do a lower rate, they would have a high number of cases to teach the residents and the fellows.
Yeah, I absolutely agree with you, but I go back to cholecystectomy. Mm-hmm. You know, 25 years ago, it was all open. And today you open only if you have, I don't know what. I mean, so it doesn't matter if it's a community hospital or it's a, so I'm not saying that you're not right. I think you are right. But in North America, the situation is that you are trained, but you almost never see minimally invasive procedure. Ottawa is different. You know, you have emphasized this. I don't know what the situation with the mitral right now, but CABG, we all know what's going on.
Yeah. Well, I think the center is pretty busy with the minimally invasive. We have a question from Dr. Chen, who is one of our cardiac anesthetists. So he says, Dr. Ad, some of you are early thoracotomy-based patient. I think he's mentioning the minimally invasive surgery, not just big thoracotomy, just a small thoracotomy. Experience pain compared to sternotomy. What is your approach regarding analgesia perioperatively?
Yeah.
For minimally invasive surgery.
Yeah. So we were the first one, you know, with Jimmy Cox, about 20 years ago that we did cryoanalgesia. I was very dissatisfied with the results then, so we abandoned it. And what we do today, we leave an on-cue pump with two catheters, one along the incision and one goes up the intercostal space, and the pain is manageable very, very well. Sometimes the patient that leave the hospital day 2 after surgery go home with the on-cue pump. Also, we found in appropriate patients, but especially the young ones, that Toradol, the anti-inflammatory, is a huge asset for them. In general, I must say that careful dissection, careful spreading, and careful closure also impacts the amount of pain you have. Yeah, but the myth that sternotomy is less painful is not that true in many cases.
So I think we have Dr. David Burney. David is cardiologist. Was the head of electrophysiology for some time. Is the incoming head of cardiology actually at the Heart Institute. And David, I'm sure you know him. He's going to actually co-chair the session after this session with the resident rounds. So David, is your hand up for a question?
Yeah. Yes.
Thank you.
It is, a comment, two comments. First was to thank you for your great talk. The second was to defend multi-center clinical trials, because I'm a multi-center clinical trialist, and surgeons should try and do them as well. LEOS 3 has been a wonderful trial. You guys did that, and you can stratify by center to control for the issue that you mentioned. My question really is really related to standalone ablation and your perspective as to why it's not really taken off in the US. You showed a very flat uptake, and is the future hybrid ablation, with the EP doc in the lab along with you guys, the EP doc checking the lines, etc.
Yeah, I like to mention that I saw first for the multi-center RCTs. I think it's important. Don't misunderstand me. I don't want to be on the wrong side of the argument, but I think it's very, very problematic, and we can maybe sit and talk. Not everything can be controlled, and this is something that bothers me. For the ablation, I always think in a way that I'm not fanatic, although I sound fanatic about the MACE procedure and others, or minimal invasive mitral versus not. I'm actually not. I'm trying to be very reasonable as to what I offer my patients. There are two problems with atrial fibrillation surgery in the US or worldwide for standalone. One is most surgeons are not educated about what atrial fibrillation is. So you can't treat a disease if you don't understand the pathophysiology. That's my opinion. I may be wrong. Being a technician is not helpful in the long run, not to you and not to your patient, or vice versa. Secondly, the decision making should be multifactorial. There are patients that there is no solution but the full MACE procedure. There is a very safe procedure, and I can show you safety profiles of mine and others that have done hundreds of these without many major complications, with a very good success rate. But not all patients would have to go through it, and hybrid approaches, I think, are really, really the way to move forward. The problem we have right now with hybrid approaches is that beating heart, unipolar ablation coming from the outside of the heart is the most inefficient energy source out there, and there are a multitude of good studies coming from Germany and also from Rav Damiano's lab to show that. So I think we have to find the best hybrid approach. And I consider my MACE as also hybrid, as part of hybrid, because I want all of them to go back to the lab. I know it's a long answer, but mind you, the first 64 cut and sew MACE procedure all went to the lab. People don't really know that. All went to the lab for a very, very detailed EP study. and correction and so on and so forth with Bueno when he was alive and in St. Louis. So I actually want to go back to it. It's hard to convince a lot of EPs, but I think surgeon alone cannot treat atrial fibrillation when it comes to the persistent, long-standing persistent, and EPs in most cases after the second failed ablation and so on and so forth probably would enjoy the help of surgeons to treat their patients. So that's the way of the future.
Thank you very much, Niv. I'm sure we can have more discussions with David. David is actually co-chairing the following session. So I think that we are just 2 minutes past 8:30. I know many people will go to work in the ORs now and the cath lab and EP labs and other things. So I want to thank Dr. Ad for his wonderful talk. I want to thank everyone on the call to attend the meeting. And I think it was a great session addressing important problems as mitral valves and atrial fibrillation. And I wish you a very good day. I thank Dr. Ad again, but for those who are going to be attending the next session, we need to actually step out and step back in. So those who have been invited to the residence round and with Dr. Ad and Dr. Burney, please join in a few seconds. And thank you all and have a great day. Thank you. So Niv, just disconnect and reconnect. Thank you.
Thank you.